Let's continue on with part 3 of the high-risk newborn. All right. This is just some more terminology on this slide to get you familiar with the preterm baby. Big thing I want you to remember is that preterm babies can have variable immaturity of all systems, of their respiratory, of their cardiac. They can't, their thermoregulation, they can't control their temperature, of their GI system, their renal system. Every single one of these systems has variable immaturity. That's what makes treating a preterm so challenging, and every preterm is different. The preterm infant, these are just some common assessment findings. Again, I want to emphasize on their skin, they will have an abundance of lanugo, especially on their face, shoulders, and their back. Again, these are just more assessment findings. As far as their posture and tone goes, most preemies are going to be very flaccid. They will be hypotonic. So one of your goals as a nurse in caring for them is to overcome that. You want to position babies so that you can keep them midline. Look at the second baby all snuggled up in the snuggle up. See how the baby's extremities, the baby's arms and legs are flexed. And we've kept the baby cushioned and positioned where everything is towards the midline, which is absolutely perfect. The poor baby on the left is not in a developmentally appropriate bed at all. Looks like the baby has about one arm flexed, but nothing else looks very healthy for them. It's also important to note that preemies have a very hyperactive or exaggerated response to stimuli. As far as cardio-respiratory difficulties, a lack of surfactant causes a decreased ability of the lung to fill with air because the alveoli collapse or they become atelectic, which causes an increase in the inspiratory pressure needed to expand the lungs. As a result, babies become hypoxic. Pulmonary blood flow is inefficient and their energy is completely depleted. It is common to see some left to right shunting of blood through the PDA back into the lungs. And you can read again about how a PDA affects all of this. Blood vessels cannot constrict as well due to a lack of muscle development in response to the hypoxia because they're preemie. That's why they don't have the good muscle tone and development. The left to right shunt is characterized by a back leak of blood from the systemic to the pulmonary circulation. As a consequence, the pulmonary circulation carries not only the blood that legitimately enter the right atrium and ventricle through the superior and inferior vena cava, but it also puts up with the additional blood entering through the ASD, VSD, or PDA. Blood volume and pressure in the pulmonary circulation becomes abnormally high. If the shunt is significant, there is progressive damage to the pulmonary vasculature and the gradual development of irreversible, hear that? It's irreversible pulmonary hypertension. The pressure in the pulmonary circuit may ultimately exceed the systemic pressure with reversal of blood flow from the right side into the circulation of the left. This is called Eisenmenger syndrome. To maintain the respiratory function? Well, we're going to keep the head midline, in line with the chest, and the neck gradually extended into the sniffing position. You're going to monitor resting whispers and their pattern, as well as bilateral lung sounds. Observe for signs of respiratory distress, such as nasal flaring, grunting, retractions, or periodic breathing or apnea. Surfactant administration is probably the single most important development in the survival of neonates. I think I've already said it numerous times probably. Surfactant was going to be squirted right down the ET tube and it just soaks into the lungs. After surfactant administration, we do not suction for at least an hour so that you don't suck out the surfactant. Wait longer than an hour if you can. We will also monitor blood gases as ordered, making sure to consider the physical assessment of the neonate when you are interpreting the blood gases. All right, I feel like I beat hypoglycemia to death, but it's a very important concept for you guys to understand. The excess insulin exposure comes from the baby being exposed to high blood sugar from the mom. Now, I also need you guys to remember that preterm babies don't have full glycogen stores, and they don't have adequate BAT fat because they were born too soon. They didn't get it. Their shipment of BAT fat was delayed. And this slide just goes over some of the common symptoms of hypoglycemia in a baby. An exaggerated moral reflex can also be added to the list. As far as hypoglycemic evaluation, one of the key things I want to make sure you guys understand is how to collect a good quality blood sample from a baby's heel. Because you don't just click the heel and hope for the best. No. And you need to pay attention to where you are clicking on the heel. I've seen nurses screw up, and I've seen marks where they've checked the blood sugar all the way down to the baby's arch. That is not where you're supposed to be collecting the blood sample. Their lateral heel is always the preferred site. Always warm the heel. Always. Because when we warm something, what does that cause? Vasodilation. So you're going to get a better, more accurate sample than if you try and click and take blood from a, ice cold foot. And then also, you should be aware that there are other electrolytes that are affected in the presence of hypoglycemia, namely hypocalcemia. They go hand in hand. In the NICU, we actually routinely bolus the preterm neonate with calcium gluconate to combat the hypocalcemia. No, but heat loss is a major problem for the preterm infant for two reasons. Recall that they have insufficient glycogen stores and they lack brown fat to burn up for heat. Also recall that they have very thin skin. They don't have a lot of subcutaneous fat. And they have a big body surface in relation to a tiny weight and poor muscle development, so they can't even hardly flex their extremities. So basically, they can't make a lot of heat and they can't hold on to even what they make. The thin skin predisposes the preterm infant to both fluid and heat loss. In addition, insufficient glycogen stores in the liver and lack of brown fat places infants at risk for hypothermia. In cold stress, babies release norepinephrine to stimulate the metabolism of brown fat. Hypoxic babies do not have the extra oxygen to handle this, so they just get colder. They lack the muscle mass, too, so they can't even shiver. Isn't that sad? You can't even shiver. Just provides a very nice table that just shows you how cold stress affects so much in a baby. Maintaining a neutral thermal environment. What are we going to do? Well, obviously, we're going to keep the skin dry, promote skin to skin with mom or dad to baby. We administer only warmed or humidified oxygen. You'll never see, even back in the delivery room, unless they're just doing some flow by. They will always administer warmed and humidified oxygen. We pre-warm surfaces, such as including the equipment. So when labor delivery calls and they say we have a baby about to be born, we go ahead and kick on that radiant warmer. And we want that bed preheated in case so that it's warm when we have to lay the baby down. Keep the beds away from drafts. When babies are in isolettes, we also use the little probe to help monitor and track the baby's temperature. It's also important to warm a baby's milk before you feed them, unless for some reason it's contraindicated, but we generally warm them. Think about how much you guys get cold after you eat a big meal, or especially after you eat something cold. Not only do you sometimes get brain freeze, but then you get like whole body cold because you just put something very cold in your warm belly. We keep babies in a double-walled isolette as indicated. And again, I've already mentioned the skin probes. Other considerations to include warming feeds before feeding, which we just talked about, and once the newborn has transitioned to an open crib, dressing them in layers. Of course, always give them a hat. Why? You're right, because babies lose a lot of heat through their head. All right, remember that preterm babies are at higher risk for infection than term babies are. A, because they have immature skin, and B, because they undergo invasive procedures. Remember how fragile the skin that they have can be. Skin is your frontline defense against infection. If you don't have your skin providing for you and defending you, you are going to be you're going to be up a creek without a paddle. This is why hand washing is so critical in the NICU. Because babies don't have good skin to help prevent nosocomial infections. Babies get some IgG, immunoglobulin, from their mom during the last trimester, except if you're born preemie, then you didn't get that. You, you left the train station before your train arrived with your shipment of antibodies. It's also important to know that the bowel is highly susceptible to infection, but Mother Nature has a plan for that because IgA is found in breast milk and is considered to be protective for the mucosal surfaces of the GI tract. Prevention in the preterm baby includes wash your hands, scrub the hub. I don't care if you just pulled that hub out of the sterile package. Once that hub is out, if it has touched air, you need to scrub the hub before you access it, especially if it's a central line. Drives me crazy when I see other nurses, like in the OR, and they just pick up a clave, like one of the little extension pieces, and they just piggyback right in, and they don't bother to clean that port at all. And I always think to myself, thank you for just injecting me with bacteria that my poor immune system is going to have to work so hard to overcome. That's awesome. And the rest of the interventions you can read on your slide. In the preterm neonate is of particular significance as their extracellular water content is nearly 90% as opposed to the 70% of a term newborn. In addition, preterm newborns have a very large surface body area and a very limited ability to manage fluid shifts, making them quite susceptible and vulnerable to dehydration. The GFR is proportional to the gestational age. The lower the gestational age, the lower the GFR. GFR, your gross filtration rate, is also decreased in the presence of anything that causes decreased renal blood flow, such as respiratory distress, hypotension, and hypoxia. Bicarb is excreted at a lower serum level, and acid is excreted even more slowly. So after a period of hypoxia, the kidneys need extra time to process that and excrete the lactic acid that accumulates. Maintaining the fluid balance of a preterm baby or a high-risk newborn would include all of the interventions that you see on your slide. Hydration, again, I'm just going to hit it again, is a big deal in the preterm neonate. How do we judge what is when we judge hydration? Yeah, it's through urine output. Urine output should range from 2 to 4 milliliters per kilogram per hour, or 8 to 10 wet diapers for babies not on accurate INO. If you're on accurate INO, well, then you'll weigh the diapers and you'll have an exact count. You'll know exactly how much the baby's peed. But when you're just doing diaper counts or diaper checks, you don't know. So you aim for 8 to 10 wet diapers a day. Anemia in the newborn results from, and you guys can read your slides. It can also result from excessive hemolysis of red blood cells. And then we have something called physiologic anemia of infancy, and I'm pretty sure we talked about that in the well baby stuff. But it's just a gradual drop in hemoglobin over the first 6 months of life. Usually this is self-correcting. Because polycythemia affects the consistency and the viscosity of the blood and results in extra circulating blood volume, newborns may demonstrate cardiac symptoms such as tachycardia, symptoms of CHF. Preterm infants may also show respiratory distress symptoms in the form of grunting, tachypnea, and cyanosis related to hypoxia. Feeding intolerance is also a sign of polycythemia because specifically it's an increased risk of NEC, along with poor feeding, vomiting, hypoglycemia, and hypocalcemia. Now, the impact of polycythemia on your kidneys is also significant, leading to a decrease in their urinary output, hematuria, proteinuria, and even renal tubular damage. Some of the neurological impairment includes jitteriness, irritability, decreased tone and activity, and lethargy. In extreme cases, polycythemia in the preterm infant can lead to seizures and stroke. So what is the RN to do? Well, you're going to do what every good RN is going to do, which is assess, record, and report the symptoms of polycythemia. Lots of times babies are going to be asymptomatic, but sometimes they are not. As far as treatment goes, it depends on what kind of anemia. If it's asymptomatic, then they'll just monitor the child with hydration and monitoring. But if it's symptomatic anemia, then they can do a partial exchange transfusion. Partial exchange transfusion means that they put in a UAC line in the baby, and they take blood out and they replace it with fresh frozen plasma, albumin, or saline. GI difficulties that NICU babies face is a high aspiration risk. That can be due to a poor gag reflex. Maybe they have incompetent sphincters like stomach sphincters and esophageal sphincters. They have a poor suck and they have a poor suck and swallow reflex. I've already talked about the increased caloric needs that NICU babies have. The caveat is they oftentimes have difficulty digesting and absorbing nutrients due to their organs' immaturity. So there's feeding intolerance / necrotizing enterocolitis. NEC is a devastating disease, absolutely devastating, because it can kill babies within hours. I've seen a baby at the beginning of my 8-hour shift that was awake, alert, oriented, seemed to really be, I say awake, alert, and oriented, but we all know that babies really can't. We can't really truly check that. But the baby was appropriate. And 3 hours later, when I did my first assessment, the baby had changed. There was a change of behavior. Baby wasn't quite as active. And the nurse in me thought, well, you can't be animated and hyper all the time. However, you gotta be more than just laying in bed like a wet noodle. Cysteine, histidine, and taurine are essential amino acids for preemies, but not for term babies. This is because they have a limited ability to convert essential amino acids to non-essential amino acids. They also need a higher concentration of whey protein than casein due to the inability to handle increased osmolarity of formula because of kidney immaturity. Whew, that was a mouthful, right? Premature infants are also deficient in calcium and phosphorus because 2/3 of those mineral deposits are made during the third trimester. And of course, because of their untimely birth, they are usually born before that third trimester, or at least before those minerals are deposited. Finally, preterm babies have increased metabolism and O2 requirements associated with daily activities such as sucking and swallowing and just simple digestion of their PO feeds, and that can compromise the GI integrity. As far as nutritional support in the NICU goes, breast milk is best. Oftentimes, preterm babies will get small volume feeds very early on just to soothe and coat the gut. Then, if any kind of problems occur with the baby at all, they stop feeds and they will rest the gut with any signs of intolerance. Learning to bottle feed or learning to breastfeed is a slow and a lengthy process, and it takes an immense amount of patience on the part of the mom, the baby, and the nurse and any other support staff that are working trying to help with those things. Well, our goal is to get them off TPN and lipids as soon as possible because the fewer days of TPN, the decreased risk of cholestatic jaundice. The other big thing the other big reason why we try and start feeds ASAP is for the increased muscle maturation of the gut function and increased tolerance of feeds. Those are all very positive things. Oftentimes, OT or the speech language pathologist will consult as needed. When the preemie babies are going to take their food by gavage tube, it's important to remember how to measure and how to place an OG tube. If you are unfamiliar with this, you need to look it up. Feeding in the NICU is a very fun thing for parents to learn and a very frustrating thing for parents to learn. Bottle feeding often requires the assistance of the OT or speech language pathologist. It's difficult to find a bottle that the baby can drink from and not drown. Oftentimes, you'll see babies PO feed with either a slow flow nipple or with something called a Haberman. Breastfeeding provides a skin-to-skin opportunity and it increases bonding. It helps to calm the babies and it helps with mom's milk supply. Honestly, it helps babies escape the NICU a lot faster. Babies oftentimes do better with breastfeeding than they do with bottle feeding. I believe I told you this when we talked about infant nutrition already, but you do know that the composition of breast milk for a preterm baby is different than the milk that a mom would make for a full-term baby. So some of the neurologic alterations for a preterm baby that you should know about. Myelination begins in the second trimester. Rapid brain development occurs in the third trimester, and that's going to be a lot more apparent when we go to the next slide. Some of the other common problems, one would be an intraventricular hemorrhage, or we call it an IVH. Now this can be sorted by different grades, anywhere from grade 1, which is very mild, to grade 4, which is devastating. IVH, or bleeding in the brain, leads to a number of long-term sequelae, including seizures, hydrocephalus, CP, and mental retardation. Babies who are less than 34 weeks are at higher risk of IVH. Until 34 weeks, the brain ventricles are lined with germinal matrix. It's highly vascularized, and those vessels can rupture in response to hypoxic events. Basically, neurons that fire together wire together, and those that don't won't. Obviously, the closer to term that you are born, the better, more mature your brain is. Babies can have seizures. They also have altered behavioral states and reactivity periods. Preterm babies tend to have a more disorganized sleep-wake cycle. This is one of the reasons why we do developmental care in the NICU. It's the way that you take care of babies, and it shapes the people that they become forever. Just so you know, when you do NICU nursing, you are changing, absolute certainty, you are changing the course of how a baby will respond to things for the rest of that child's life. So how you do things, how you care for that baby really does matter a lot. The brain of a 34-week gestation infant is only about 65% of the weight of a full-term baby's brain. FYI. Random cocktail trivia for you. Picture because it just shows fetal brain development. I want you to look at the picture of the baby at 6 months of age, or 6 months gestation. Do you see a lot of gyri and sulci there? No, you don't, because that brain, in comparison to the brain of the 9-month gestation, there's lots and lots of gyri and sulci. But at 6 months, that's 24 weeks. That's the soonest that a baby can be born. But do you see why the child is going to have seizures? Do you see why they're going to have neurological issues? That brain is nowhere near developed. And yet we are placing demands on that little fragile brain at 6 months, at 7 months, at 8 months to function as a fully developed brain. And it just is not fully developed. But it really puts into perspective when you see that brain of a 6-month gestation baby. It's a great graphic. It's one of my faves. And that concludes part 3 of your Chapter 25 NICU unit. Thank you for listening, and my apologies for yawning so much. It is very late.